Thank you very much for your kind introduction and invitation. My brief is to talk about vitrectomy for ocular trauma in traumatic PVR. This is my financial disclosures. I don't think this will interfere with my talk. Just a bit about epidemiology. Ocular trauma, as has been mentioned, is a major cause of ocular morbidity and the leading cause of monocular vision loss. It's obviously more common in the young and younger adults. In a major review of 1,564 patients, PVR was the main cause of final vision being poor. PVR is estimated to be 10 to 44%, and this essentially depends on what the cause of the injury is. I'm only going to concentrate on open globe injuries. We're not going to look at closed globe injuries because the rate of PVR in closed globe injuries is very low. So if it's a perforating injury, it's almost 43-44%. If it's after rupture, it's 21%. The risk factors for PVR development are male gender, perforating injury, as mentioned earlier, vitreous hemorrhage, poor pre-op vision, involvement of anterior and posterior segments, vitreous prolapse, expelled lens, posterior capsule damage, choroidal hemorrhage, and persistent intraocular inflammation. Vitreous hemorrhage was the strongest independent risk factor for predicting development of PVR. A long posterior wound and persistent intraocular inflammation were also important risk factors. The time of injury to the time of onset of PVR was shortest after perforation, which would make sense considering that is also the highest risk of developing PVR. Now, PVR is normal wound healing gone a little bit excessive from our point of view. It's an inflammatory response. It's worsened by vitreous hemorrhage, exposure to lens proteins, presence of an intraocular foreign body, which leads to breakdown of blood-retinal barrier, expression of various cytokines, growth factors, which cause RPE cells, fibroblasts, and glial cells to migrate, proliferate, change their pattern of gene expression and forming membranes. Most frequently, the retinal detachment is associated with the traction of these membranes, not always associated with the break at the time of injury. As I mentioned before, the issues to consider are open versus closed globe injuries, and open can be separated, as has been mentioned earlier, into rupture, penetration, perforation, and I will concentrate on the open globe injuries. We should think about this sometimes multi-stage approach, because often one surgery is not enough and we may need to do more. There's a mechanical component, which is the vitrectomy. The timing of surgery is also a little bit controversial, but more people are settling on earlier surgery. The pharmacological adjuvant therapy is very important. I think that's something that we can get a lot of help on, which will come in the near future and which will help us a great deal in dealing with the mechanical component. The other issues to consider are to use an explant or not, and to save the lens or not. So let's look at pharmacotherapy. This involves the inhibition of growth factors, cytokines, or their actions, inhibits intracellular signaling pathways, alters cell function through somatic gene therapy. It's very complex. It's very multifactorial. Number of cytokines, platelet-derived growth factor, TGF-beta, insulin-like growth factor, VEGF, and numerous interleukins are involved. I remember while doing this talk, I looked at a paper and I could not understand what they were talking about, the basic sciences of it. So I'm not even going to try. But the main point of that, it is very multifactorial, and I think that's an area that we can get a lot of help, which will happen in time. If you look at what's been tried so far, there's been no benefit of periocular triamcinolone for surgery for established PVR at this point in time. We still use lots of topical steroids, but there's been no proven benefit of periocular triamcinolone. Adjuvant daunorubicin infused at the time of vitrectomy reduced reoperation at 1 year. However, there's no difference in vision. I guess that's the bottom line of having eyes. So far, there's been no proven benefit shown. Use of 5-FU and low molecular weight heparin added to the infusion fluid initially showed promise, but has been inconsistent. There's been a Cochrane database review which suggested the evidence doesn't fall one way or the other. People have looked at mitomycin C, hypericin, Taxol, have all shown promise. They act at peaks PICS, light, use the instruments that is required at that point in time to ensure that you've got all the PVR membranes removed. Gauge of surgery really depends. We all want to do small gauge surgery, really, but it really depends on what your other plans are. If you want to put a buckle on, then maybe you might as well just use a 20 gauge because you're going to have to suture it anyway. If you plan to do a fragmentome because you need to get rid of the lens to make sure you've got good, adequate vitrectomy, then you might as well use a 20 gauge. And if if there's a foreign body involved, you probably need a 20 gauge. So it depends on whether you've got other issues you want to deal with apart from just the PVR. Kuhn et al. Suggest late chorioretinectomy for significant PVR. And one should not underestimate a multidisciplinary approach at handling ocular trauma with PVR. Some of my other colleagues in orthopedics and general surgery, if you look at how they deal with trauma, it's always a multidisciplinary approach. And those of us who have trained in retina more recently may not be as good at doing keratoprosthesis if required. So I think we should look at help from colleagues if required to ensure that we get as good an outcome as we can for our patients. Choice of tamponade, I think very few people would use short-acting gas with open globe injuries associated with PVR. Essentially either be long-acting gas or oil. And heavy liquids can be used, and even heavy oils can be used depending on the circumstances. It's a multifactorial decision. Depends if the patient is going to fly, if the patient is able to posture. So this decision will depend on what's required and what the patient will be able to tolerate. The use of a buckle or not is also an interesting thing, and there are, as we heard in the talk this morning about, there was some controversy just about superior retinal detachments alone. So more and more people are avoiding explants. But having said that, I'm certainly, I sit in the middle. I would certainly not hesitate to use an explant. It relieves AP traction, circumferential traction, helps visualize peripheral retina, and supports the vitreous base and anterior retina. Some of the explants which are commonly used for this kind of case would be a 240-270, a 42 band, a 575 Ross band, or a 276, 240-270, depending on how much support you need. And primary buccal placement in a model of open globe injury, in an experimental model of open globe injury, suggested it reduces fibrovascular proliferation. To remove the lens or not is the other question, and do we take out the lens, do we leave the capsule? This all really depends on the primary aim in PVR related open globe injuries is to stabilize the eye. The lens, if it needs to go, it needs to go. You can put there's so many excellent techniques of putting iris fixated, sulcus fixated, scleral sutured and ACI wells. I think that should be the least of our worries if we feel that the lens needs to be sacrificed to maintain the globe and the retina. IOL implantation can be deferred depending on what the case is at the time. So in conclusion, there are some questions which still need to be answered. The timing of surgery is certainly not defined, but most of us would agree that we're doing surgery earlier and earlier. I think pharmacological component of it will help us a great deal as that comes online to deal with PVR. We should consider this as a multi-stage and multidisciplinary approach, I think, to deal with these cases effectively. Thank you very much for your time and attention and the opportunity to present.